Everyone, and welcome to the webinar, Integrating Routine HIV Testing into Primary Care, Strategies for Improvement and Partnership. My name is Molly Mindbreath, and I will be co-moderator for today's webinar, which is a production of the National Healthcare for the Homeless Council, with support from the Health Resources and Services Administration, Office of Special Population Health. Katrina Twilley will moderate the Q&A session at the end of the webinar. The session is being recorded and will be archived on our website at www.nhchc.org. This is a one-hour presentation with the last 10 minutes reserved for questions and answers. Below the presentation slide on your screen, there's a chat box for participant questions and technical issues. If you are experiencing an urgent technical issue, please call Krista Maya at 615-226-2292 for immediate assistance. Please type your questions for our presenters into the chat box at any time during the webinar. A selected number of questions will be answered at the end of the presentation during the Q&A session. Upon exiting this webinar, you will be prompted to complete a short evaluation. Please complete this evaluation to ensure that we are meeting your educational needs and have an opportunity to address your suggestions. Thank you for participating in this webinar. In recognition of HIV Testing Day, this Saturday, June 27th, today's session will highlight the importance of integrating HIV testing into care, as well as strategies for improvement and partnership. Our first presenter for this webinar today is Dr. Darlene Jenkins. Dr. Jenkins is the Senior Director of Programs at the Council. She is responsible for the oversight of the Education, Research, and Special Projects divisions of the Council. She's been with the Council for the past 6 years. Dr. Jenkins received her Doctor of Public Health degree from the University of Illinois at Chicago. She also holds a Master's of Public Health degree from the University of Michigan. Our second presenter today is Dr. Philip Peters. Dr. Peters is a medical officer with the Division of HIV/AIDS Prevention, U.S. Centers for Disease Control and Prevention in Atlanta, Georgia. Dr. Peters is the activity leader for HIV testing in the Division of HIV/AIDS Prevention's Epidemiology Branch. He is responsible for conducting epidemiologic and biomedical research activities to evaluate acute HIV infection and important HIV-related co-infections. Dr. Peters received his medical degree from Cornell University Medical College. He completed his clinical training in internal medicine at Massachusetts General Hospital and his clinical training in infectious diseases at Emory University. Our third presenter today is Chuck Amos. Chuck is the Director of Performance Improvement at Healthcare for the Homeless in Baltimore, where he champions population health management and data-driven quality improvement. He has an MBA in Medical Services Management and a BS in Health IT from Johns Hopkins University. I'll now hand the microphone to Dr. Jenkins to now get us started.
Thank you, Molly. Today, in observation of National HIV Testing Day, we want to not only talk about the importance of HIV testing for people who are stably housed, but also highlight a report we published in April of this year. This report contains the results of a survey we administered to homeless care providers to assess their rapid HIV testing practices. We know HIV testing and counseling are the cornerstone of the HIV prevention response, and that testing allows individuals to know their HIV status and to access appropriate services, especially as health centers concentrate on improving the quality of care and improving the quality of care performance measure that ensures that newly diagnosed HIV patients receive a timely medical visit after diagnosis. It is even more important that testing and counseling become our focus not only on June 27th, but throughout the year. The Centers for Disease Control and Prevention recommends routine, voluntary HIV screening for all patients aged 13 to 65 years in all healthcare settings as a normal part of medical practice similar to the screening of other treatable conditions. In 2013, the federally funded Healthcare for the Homeless Health Center Program grantees provided care to 851,641 patients. Even though 740,000 or 87% of these patients were between the ages of 13 to 64, only 81,869 of all patients, or 9.6%, received an HIV test. Since the numbers of HIV tests provided to patients are not recorded by age groups in the UDS data set, it is unknown whether the patients who received HIV tests were between the ages of 13 to 64 as recommended by CDC. Also, we do not know how many that were tested actually returned for results. In 2013, the National HCH Council collaborated with Dr. Catherine Fogg from Manchester, New Hampshire, and we developed and administered a survey based on Pender's health promotion model. We wanted to assess what the HIV testing practices were for healthcare providers, not only who practice in healthcare for the homeless settings, but also in shelters and also medical respite programs. The emphasis on routine testing was based on CDC's recommendations, and the focus on rapid testing was based on Dr. Fogg's previous research, which identified this method as a facilitator that may increase HIV testing among homeless populations. Listed are the key findings from the survey. The quantitative findings revealed that for homeless care providers who responded to the survey, HIV testing and additional preventive health screens are common practices. However, the data did demonstrate that there are inconsistencies in HIV testing practices utilized by these organizations. The findings of this survey and past research reveal that healthcare providers support the value of routine and rapid HIV testing for all patients who frequent homeless care provider sites, including medical respite programs and homeless shelters, instead of testing only individuals believed to be at high risk. And finally, the results also show that respondents perceive that routine and rapid HIV testing can benefit patients, especially those who are experiencing homelessness. And those providers who are not currently offering routine and rapid HIV testing, more than 50% indicated that they are willing to be trained to administer the test. And they also think that this method can be integrated into day-to-day process without interrupting the flow of service. The full report of our findings are located on our website, which is nhchc.org. And if you Google or search for HIV, the report will come up. Thank you so much, and I will next turn the session over to our next speaker, Dr. Philip Peters.
Well, thank you very much for the opportunity to talk about implementing routine HIV testing in clinical settings. As an overview, there will be 4 components of this talk. First, I will review HIV screening recommendations briefly. Second, analyze the rationale for these recommendations. Third, assess clinical benefits of routine HIV screening. And finally, formulate application and approach for simplifying routine HIV screening in practice. So to begin, the next slides will provide an overview of the actual HIV testing recommendations to introduce this talk. This poster that the VA health system has used to introduce the topic of HIV testing to their general patient population, and I think it sums up the testing recommendations very well, because the answer to this question, which of these people should get an HIV test, is of course everyone. In 2006, as was mentioned, CDC issued routine HIV testing recommendations that are listed here. HIV screening was recommended for all patients aged 13 to 64 years of age. Opt-out screening was recommended, so patients would be told screening would be performed but had the option to decline testing. Written consent and prevention counseling was not required to be linked to HIV testing. Annual HIV screening was recommended for those at high risk for HIV infection. And of course, prompt linkage to clinical care was recommended for anyone diagnosed with HIV infection. These recommendations were to be done in accordance with any state laws regarding HIV testing. And another key part of this is that screening was recommended if the expected prevalence of undiagnosed HIV infection was at least 0.1% or higher. In 2009, the American College of Physicians also recommended routine HIV screening. And in April of 2013, the U.S. Preventative Services Task Force concurred with CDC and the American College of Physicians and gave routine HIV screening a grade A recommendation, which indicates a high certainty that the net benefit is substantial. One point to note that is slightly different from previous recommendations is that the newest recommendations now recommend HIV screening for those who are 15 to 65 years of age. So the age range was changed slightly with these newer recommendations. The next slides will provide an overview of the rationale for why HIV screening should be established as a component of standard care. First, just thinking in general about criteria that would justify routine screening for any type of a health disorder. One, the health disorder should be serious, and it should be something that can be detected before symptoms develop. Two, the treatment should be beneficial and more beneficial when begun before symptoms develop. Three, the test should be reliable, inexpensive, and acceptable to the patients who are being screened. And four, the cost of screening should be reasonable in relation to the anticipated benefits. So in general, these are guiding principles for evaluating when screening should be recommended for a serious health disorder. This figure outlines the desired outcome of routine HIV screening. First, the screening leads to an HIV diagnosis. The HIV diagnosis then leads to linkage to HIV care. The linkage to care would then result in HIV treatment. And HIV treatment has two benefits. First, for the individual, it improves survival and improves their quality of life. But then also for the community, it prevents further transmission of HIV and therefore prevents new HIV infections. So this cascade of HIV screening leading to diagnoses, leading to HIV care, has both an individual and a public health benefit. So why then does the screening have to be routine? The simple answer is that risk-based screening has not been successful. It has failed to identify a substantial proportion of people with HIV early in disease. Risk-based screening was recommended in the United States for almost 15 years. In the majority of people who were being diagnosed with HIV infection during that period of time were diagnosed in the very late stages of their infection. So we were failing to diagnose HIV infection in the early phase. Risk assessment and prevention counseling to do targeted testing are also very resource intensive. So to perform risk-based screening, you need to put a lot of resources into performing the risk assessment in every patient. Finally, we have increasingly seen that the HIV epidemic affects all populations. And so while patients with certain risk behaviors may be at higher risk for HIV infection, the risk-based testing is going to fail to identify some patients with HIV infection. Other reasons why routine testing may be preferable is that patients do not always disclose or may not even be aware of their risk. In one study from New York City, 39% of men who had sex with men within the past year did not disclose this to their healthcare provider. In another study of HIV testing in an emergency department setting, 51% of the patients who had a reactive rapid HIV test did not identify any risk behavior at the time of their testing. So simply relying on reported risk behavior, either directly from the patients or relying on the patient to report the behavior, or even if you're asking for risk behavior information, may not be completely accurate at the time you're performing an HIV test. Finally, although we are discussing routine HIV testing, most of the patients that you are providing care to have unstable housing. And as this review article from Lancet Infectious Disease demonstrates, patients who do not have stable housing are more likely to have HIV infection. So patients, regardless of their risk behavior with unstable housing, are going to benefit even more from HIV testing than the general population. The next slides will review how routine HIV screening and early diagnosis can improve outcomes if we can successfully link patients to HIV treatment. The first benefit of HIV screening is awareness of HIV status. So how does that affect HIV transmission? Well, approximately 14% of people with HIV are unaware of their HIV status. This actually represents a big improvement in awareness of HIV status. Approximately 5 years ago, this number was 21% of people. But although this is an improvement, this still represents over 160,000 people in the United States. And this has significant implications for transmission. As Marks and colleagues have estimated in a review of HIV transmission, persons with HIV infection who are unaware of their status are 3.5 times more likely to transmit HIV compared with people who are aware of their status. And this is because, as studies have shown, persons with HIV who are aware of their status change behavior to make it less likely that they will transmit infection to others. The next benefit of HIV screening is early antiretroviral or ART treatment. How does this impact HIV transmission? Well, this slide summarizes the HPTN 052 study where they looked at the impact of antiretroviral therapy on HIV transmission in discordant couples. So one partner in the couple was HIV infected, one partner was HIV negative. In the study, only one link to HIV transmission occurred among the 886 couples randomized to treatment, compared to 27 linked HIV transmissions that happened in couples that were randomized to the delayed treatment group. This reflects a 96% reduction in the risk of HIV transmission in the early treatment group. And the study has definitively demonstrated the enormous public health prevention benefit of diagnosing and treating people with HIV infection early. What about the individual benefits of early HIV treatment? This chart shows the prognosis over 5 years of HIV-infected treatment-naive patients who are just starting antiretroviral therapy. The graph is stratified by the CD4 cell count that a person is starting their treatment at. The lower your CD4 cell count, the more immunologic impairment or damage you have. And as this graph shows, the probability of death increases as your baseline CD4 count decreases, thus emphasizing the need to diagnose and treat early. In other words, if HIV infection is diagnosed too late, a significant proportion of patients will still die despite HIV treatment that may not have died if they were diagnosed earlier. In response to this data and many other studies that have had similar findings, the Department of Health and Human Services antiretroviral treatment guidelines were updated in 2012 to recommend antiretroviral therapy regardless of the CD4 cell count. This update was enormously beneficial for HIV testing because it clarified that if an HIV infection was diagnosed early, they should and would be treated. And that was really one of the reasons that I think was one of the main arguments for not screening. If there was not a recommendation to treat early, what's the point in trying to identify people early with infection? Well, there's still a public health benefit, but for the individual, you could see that argument. As you can see, the recommendation, the strength of the recommendation does vary based on a patient's baseline CD4 cell count. But as you might have heard recently, a new study was just discontinued called the START study that looked at patients that were starting antiretroviral treatment at very high CD4 cell counts, greater than 500. And even at these high CD4 cell counts, there was a 53% reduction in the risk of developing a serious illness or death with early treatment. So likely these recommendations will be revised further to strengthen the recommendation that anyone who is HIV diagnosed should be offered HIV treatment as soon as possible. So then moving forward, these slides will discuss the application and approach to routine HIV screening. Now I think the data is quite clear about the benefit, but that does not mean it's easy to implement in a variety of different clinical settings. Now, the goal of HIV screening is to try to incorporate it into routine practice and to incorporate it as standard care. Offering routine HIV screening in conjunction with other prevention screenings is one opportunity to increase the amount of HIV testing that is done. For example, blood draws are often done to check patients' cholesterol or blood glucose. That could be a good opportunity to add on an HIV test. And again, these are being offered regardless of the patient's race, ethnicity, sexual orientation, etc. Integrating HIV screening into clinical practice is the only way that routine screening will ever be feasible. An important part of the process is addressing patient misperceptions. For example, many patients believe they have already had an HIV test before, particularly if blood was drawn. And we see this in national surveys where a much higher percentage of the U.S. population reports having had an HIV test than the actual number of HIV tests we can see being done when we look at the medical record or billing side of healthcare. There are definitely barriers to implementing routine HIV testing, and these barriers vary from site to site. This was a study that looked at HIV testing in Washington, D.C. and Houston and identified different barriers in the different locations. Between both sites, patient refusal was a common barrier. That's the first bars on the top, but a minor barrier, was not something that was considered very significant by patients. Lack of funding was a major barrier in Houston, whereas lack of funding was not a major barrier in Washington, D.C. setting. A limitation of staff time and size was a major barrier. So there likely is not a one-size-fits-all approach to incorporating routine HIV testing into clinical practice. And understanding these barriers is an important first step to this implementation. This is a program that I just wanted to point out because routine testing is expanding throughout the United States, and I think there's a lot of reasons for that. I think the revision to the antiretroviral treatment guidelines has been very important. The demonstration of the public health benefit of early treatment has been very important, as well as the USPSTF task force recommendations giving HIV screening a grade A. This is a program that was sponsored by Gilead. It's called the Focus Program, and some of your sites may actually participate in this as well. But the initial phase of the program was working with many community health centers, hospitals, and community-based organizations to implement routine HIV screening services in the 10 cities that are listed here. And from 2010 to 2013, 153 partner organizations in these 10 cities performed almost 800,000 HIV tests with a positivity rate that was almost 0.7%. So a significant number of HIV infections were diagnosed in a very large testing program. In addition to efficiently providing an HIV test, which is identifying barriers and figuring out how the testing could be provided efficiently, an important part of an HIV screening program is efficiently communicating negative HIV test results. Many patients that are screened are going to have a negative test result, so this is an important communication strategy. The healthcare provider may communicate the result to patients without direct personal contact, depending on the healthcare provider-patient relationship, and provided in the same manner that other negative tests for commonly performed screening and diagnostic tests are given. For example, a healthcare provider could provide a negative HIV test to a patient over the phone, by mail, or through an online patient portal, as is becoming increasingly more common. In HIV-negative patients who are at high risk for HIV infection, communicating the negative test result may be better to be done in person, because this then gives you an opportunity to determine when they should be tested again and determine if there are any particular HIV prevention interventions that might be indicated. Repeat HIV screening falls into a number of categories, and I'll highlight really just the first two situations here. One, any patient who is receiving treatment for a sexually transmitted infection, the recommendation is to repeat their HIV screening at each visit that they are seeing a provider for an STI-related complaint or diagnosis. So even if a patient had been tested 6 months previously, if they're coming in to be evaluated for syphilis or gonorrhea, etc., they should have an HIV test performed at that clinical visit as well. The second category is patients who are at high or what we are increasingly calling substantial risk for HIV infection. This would include men who have sex with men, people who inject drugs, also patients who have had a sexually transmitted infection diagnosis. These patients should be evaluated and assessed for pre-exposure prophylaxis that I'll mention in the next slide. And if that is not indicated, then we recommend at least annual retesting for HIV. Pre-exposure prophylaxis, or PrEP, is beyond the scope of this talk, but I've added this PrEP slide because there is a lot of information at the CDC website and from a number of organizations that have full slide decks dedicated to PrEP. We have an expert here at CDC that some of you may have already been in touch with, Dr. Dawn Smith. She actively works with many healthcare organizations to help and advise them on PrEP implementation. But here listed are the PrEP indications for men who have sex with men. There are also indications for heterosexuals at substantial risk for HIV infection and persons who inject drugs. The point is that if you are considering repeat HIV testing for a patient of yours because they have substantial risk for HIV infection, I would encourage you to start thinking about PrEP. And if your particular healthcare center does not offer it, trying to figure out where there is an easy referral mechanism so that your patient could be evaluated for PrEP. If a patient is taking PrEP, what is nice is that as part of that program, they'll be receiving HIV testing conducted with their medical visits every 3 months. And the other nice thing about PrEP is that if patients are taking the medication, PrEP is the current version of PrEP, and I apologize, I should have mentioned this before, but is a component of HIV medication called Truvada that prevents a person from getting infected. But if people take that medication, it is 90% effective at preventing HIV infection. So the final part about conducting HIV testing is most importantly being prepared to communicate a positive HIV test result. These results should obviously be provided with direct personal contact, provided confidentially, provided slowly to ensure that the patient is understanding exactly the test result and its implications. And again, in addition to providing the results, there is an immediate connection to services. So organizations that are providing HIV testing already have the phone numbers they know they would need to call if a new diagnosis was made, and the mechanism that they would make a referral as efficiently as possible to an HIV care setting. Because at the end of the day, as we saw in the initial figure, the whole purpose of doing the routine testing is to get somebody started on early treatment. So if the testing is done and makes a diagnosis, but a person doesn't get onto treatment, that probably still does have some benefit, but we've really left a lot of the potential individual and public health benefit on the table. This is my last slide that has figures in it, and this talks about reimbursement for HIV testing. Reimbursement has limited the implementation of routine HIV testing. To be sustainable, HIV testing must be reimbursable, and the Affordable Care Act attempts to address this by stating that most new health insurance plans must cover HIV testing for that age range that we saw in the U.S. Preventive Services Task Force. And it should be done without additional cost sharing, such as copays or deductibles. The reality is that not all patients have insurance still, and not all insurance covers HIV testing in the U.S. This is something that we want to continue to work with you on and hear challenges and success stories about how you are able to either get reimbursed for HIV testing or not get reimbursed. Lessons learned are going to be very important and hopefully could be informative and rolled out nationally. So I will stop here. This slide points you to our websites that have a lot of additional information and free materials regarding HIV testing, including things that could be given out to patients as you're seeing them. There are a number of packages and materials. So with that, I will conclude. Again, I thank you very much for your attention. And at this point, we'll pass the presentation to Chuck Amos. Thank you again.
Thank you, Dr. Peters. So I am the Director of Performance Improvement at Healthcare for the Homeless in Baltimore. And part of what I'm going to be talking about, I referenced P4C in our slides. It's a grant program jointly funded through HRSA and the CDC that is looking to improve our HIV care. It's Partnerships for Care. I reference that some throughout my slides, but really my goal is not to focus on grant-specific work, but to focus on things that are replicable across any health center, regardless of what grants, what sort of funding systems you have in place. Now, I do talk about some systems like a population health management system, EMR systems, and these are expensive systems, but I strongly believe, and there's a lot of evidence out there across other health centers, that making smart investments in quality, the investments pay for themselves, maybe not in the short run, but in the long run. So it's important to take a long-term view of quality improvement related to both HIV and any health care that we provide. As I talk about our HIV care and the Partnerships for Care program, it really aligns with the quality improvement goals that we have in Baltimore, which are to manage population health, to measure our clinical quality, to improve our chronic disease care, and to share our clinical quality measures. I'm going to talk about our HIV care in the context of these four goals, beginning with managing population health. So population health, it's a term that gets thrown around a lot, but what is it? There are a lot of different definitions out there, as is the case often in healthcare. The IHI, the Institute for Healthcare Improvement, has a definition looking at the health outcomes of a group of individuals. But I really like the definition that Nilesh Kalyanaraman, our Chief Medical Officer in Baltimore, uses, which is how we take care of all of our patients, including the ones who aren't in front of us. As a Healthcare for the Homeless project, we have a lot of patients who don't regularly come in for care, who don't keep their appointments. So they're part of our population, though, and how do we take care of them? So population health management, as we look at a system to help us with that, what does that mean? Is it the same as an electronic health record system? It's not. This is an image I'd like to use to describe what an EHR is, and it's like a library. It's filled with books, and each book is a patient, and the patients have chapters and pages and paragraphs and words and letters, and all of those things are data elements, potentially millions of data elements for a single patient, let alone for the entire population. But what's missing in this image is a checkout desk. What the population health management system becomes, it's our checkout desk. It's our way of getting those millions of data points back out of the EHR in a usable way. And as far as the checkout desk that we use in Baltimore, it's a system called Azara Drives, but there's a lot of systems out there. There are vendored systems like Eye2Eye. There's networks that specifically serve FQHCs like the Alliance of Chicago and OCHIN. And then a number of organizations invest in IT and data teams that develop their own reports to manage population health. So there's no one solution. But whatever solution an organization picks, the benefits are huge. This is a report that I ran out of our system. It took me longer to go through and de-identify this data than it took to run the report. And this is a registry of HIV patients for one of our providers, looking at who they are, when they were last seen, when their next appointment is, what their CD4 results were, when their most recent test was done, viral load results and test dates for female patients, PAP tests. There's a lot of information here that a provider can look at and immediately get a snapshot of where their HIV patients are. It's also looking at how we care for our patients as individuals. This is a huddle report, or what Azara calls a patient visit planning report. And what it does is a provider can run this at the start of the day. We work with our medical assistants as well. And for every patient who's on a provider schedule, this proactively gives the provider a heads up on some key information. So knowing that a patient has HIV, in this case, and this is one of our actual patients, we have comorbidities of diabetes and hypertension, and some things that we might want to be paying attention to. Looking at the fact that the last A1C result was just a little bit over 7. Blood pressure was a little on the high side. So it's a snapshot, kind of a cheat sheet for the providers, so they get this information before they ever see the patient. Then population health is also looking at our population as a whole, how we're taking care of our population. This is the same measure that we looked at earlier in the slides about our newly diagnosed HIV patients. So for all the folks who we've diagnosed in 2014 in Baltimore, how are we doing as far as getting that follow-up appointment with them within 90 days? We're not doing great, to be honest about it. This is our 2014 UDS measure, and we've got some room for improvement here. This is the kind of data that we can get real time out of a population health management system and monitor as we go month by month, quarter by quarter, to really see where we need to make improvements and how effective those improvements are. Looking at our second quality improvement goal, it's to measure clinical quality. And last year, in 2014, organizationally, we identified 32 measures across all of our services, not just medical, that were important to us as an organization, evidence-based measures. 15 of those aligned with the 2014 UDS, and then 17 measures looked to other evidence and guidelines, such as pediatric fluoride varnishes, for our patients, for our children and adolescents. Again, in the beginning of this deck, I talked about replicable work, and this is the kind of work any FQHC, any Healthcare for the Homeless project can go through and look at your capacity, look at your patients, your providers, and identify these kinds of measures. There's nothing grant specific about this. This is work that any organization can do. But looking at HIV, how within these 32 measures, we did identify 3 in particular that look at our HIV population, monitoring our patients with undetectable viral load, looking again at the newly diagnosed HIV patients, have they gotten their medical follow-up in a timely manner, and then we have an outreach team that works to re-engage patients after one missed appointment. We start doing outreach to find out what's happened with that patient, what can we do to re-engage them in care. But also looking at the Partnership for Care grant, we're using this as an opportunity to add a few more measures to these prioritized goals, including looking at our patients with 1 or more lifetime HIV tests, so getting quantifiable data that we can look at in a dashboard form to know exactly where we are and what our opportunities are. Looking at STD screening, ART, there's a lot of opportunities that we're looking to improve upon here. Our third goal is to improve chronic disease care. And we're treating HIV as one of many chronic diseases that our patients face, but it's not the only chronic disease. And our idea with the Partnerships for Care opportunity, and again, it's not exclusive to this P4C program, any health center can do this, we're going to start by looking at our workflows around HIV to find out where are we dropping the ball in patient care for our patients, and where are the gaps, and how can we improve them. But then, by looking at HIV, how can we pick those processes up and apply them to other comorbidities? Because all of our patients are going to benefit. 8% of our HIV patients are diabetic, 40% are hypertensive. And when we look at our general population, we have over 700 diabetics, over 1,500 hypertensive patients. There's a lot of opportunities here to improve care both for our HIV positive population and for our population as a whole. Just again, looking at opportunities to improve care across the board. Now, relationships, and an FQHC and a healthcare for the homeless setting, we don't have the resources that some of our community partners, some of our specialists have for HIV care. So what do we do? What can any organization do to improve that network? One of the big things to do is just network in the community to identify potential partners, whether that's continuing education events, whether it's presentations that are being given by a hospital or by an HIV specialist. There's a lot of opportunities to get out there and meet the people who are really doing specialized care. Attending the CE seminars who are given by these specialists to help build relationships there. We found that inviting specialists to come to our center and to lead lunch and learns, it's been an effective way to share information, not just with our providers, but then also to build an ongoing communication with specialists who otherwise we might not have access to. Likewise, whenever we encounter something that's particularly challenging with a patient, use that as an opportunity to reach out to our network, the network that we're building, to figure out how can we utilize these people to strengthen both the care that we give and the network that we have as a community. And then creating formal relationships through MOUs, but still maintaining the informal relationships that come out of networking. Workflows, we've just hired a project lead for the Partnerships for Care program. She's an RN with extensive QI experience, so beginning by looking at HIV and then again figuring out how do we pick up the improvements we make for our HIV population and apply them to some of our other populations. Identifying and addressing the workflow issues in HIV care. What happens when our HIV testers are on vacation or go out to lunch? What are the workflow issues around that, and how are we addressing it or not addressing it? looking at, then again, how can we take the lessons we're learning and apply them across the organization so all of our patients benefit from them. Our HIV testing improvements, those workflow improvements can be applied to Hep C testing. Or as we look at our actual testing processes for doing the 4th-gen HIV tests, how do those workflows impact our diabetics who need hemoglobin A1C tests? And then partnerships. I talked about the partnerships with specialists, but also working to build partnerships with other health centers in Baltimore and around Maryland so we can do things like share data and just communicate better to figure out when we have a patient who disengages, have they engaged in care somewhere else? Do we need to send that outreach team out, or do we know that they're already at the clinic up the street? Working with our health department to figure out more effective ways to share and use data that drives our quality. And then nationally, looking to other health centers, whether it's Healthcare for the Homeless projects or community health centers, to discuss the problems that we all face and identify best practices that we may have developed internally. Our 4th goal around quality improvement is sharing these measures. And the big area where this really applies with our HIV testing, it's creating transparency with our patients, with our staff, with our board, and our community partners. But we really view it as an opportunity to engage patients in ways that they're not currently engaged. Because if we can educate our population, and our entire population, I don't just mean our HIV positive patients, if we can educate the people we serve on the importance of HIV testing, and if we're transparent about how we're doing, if we're at that 9.6% testing rate that was shown in an earlier slide, by educating our population, we have an opportunity for them to come to us and hold us accountable for the work we're not doing. It's a dream to have patients come to us and say, hey, you haven't tested me for HIV, why not? So using transparency as a tool to help us empower our patients to hold us accountable to doing better work. I want to wrap up just reiterating what I started with. Some of these interventions are not inexpensive, but they pay for themselves. I've talked to numerous health centers who have invested in systems. We are only about 6 months into our population health management system, but we're already starting to see returns. And these investments, they really do pay for themselves if you budget them out and look at them as long-term investments. On that note, I'm going to pass the presentation back to Patrina for questions and answers.
Thank you, Chuck. I will now begin the Q&A session. The first question is for you, Chuck. When operationalizing routine HIV testing, would you recommend doing a diagnostic test where blood is drawn or a rapid test for the initial screening or diagnosis? And also, is there any evidence that receiving a preliminary result before leaving the health center has impacted engagement in treatment?
So to your first question, yes, all of the above. Currently, we're using rapid testing for our non-medical patients. So if we have an addictions patient who's newly engaged in care, we'll do a rapid test and as sort of a first pass before we do that blood test. On the medical side, we regularly do the 4th generation testing, but then that's really it's a big part of the improvement processes that we're trying to work on, the workflow, as far as seeing, okay, is what we're doing now the right way to do it? And what can we do to improve that? So we may find down the road that, okay, the rapid test isn't the most effective way. What can we do instead? So we're constantly looking to improve that. As for the second part of your question, is there any evidence that receiving a preliminary result before leaving the center has impacted engagement in treatment? I don't know. It's a great question. I don't have data on that yet. I'm not sure if there's literature out there. If any of the other panelists have information on that, it'd be wonderful to share. Otherwise, if I find anything, I will certainly follow up through the council.
Great, thanks. Phil, can you also add to that question?
Yeah, I would agree with what Chuck just said. I think when you're thinking about sending the diagnostic test, like the fourth generation, to the laboratory versus the rapid test, you have the benefit of doing the lab test is that it's, there could be some operational benefits, but it's also a more sensitive and accurate test than a rapid test. And so if you have a reliable method to get in touch with the patient to give them their test results, then that would be preferable. But for people that you're seeing and you're not quite sure when you're going to see them again, or maybe this is the first time you're seeing them, then the benefits of rapid testing increase, because if you have a positive result, you could, obviously give them that result right away and link them to care right away. The only other thing I would mention is that the rapid tests, there is one, and there's going to be a second one that comes to the market that can be done on an oral swab. So there are some oral swab options, but most of the rapid tests are finger stick blood tests. And studies that have compared the oral swab performance versus the finger stick performance, the finger stick usually is more accurate. And so even the devices that do the oral swab, they have an option to do it on a finger stick. And so we always recommend doing the finger stick unless it's the patient's preference and they don't want to do the finger stick. Then the oral swab is obviously better than not doing a test. So that would be a good situation for the oral swab.
Great, thank you. And I'll just do one last question. This is for you, Dr. Peters. When a lack of funding and or resources is a primary barrier to doing routine testing, how is this addressed within the health center, and how does this also address bundled screenings?
And I'm assuming that the bundled screening is talking about getting reimbursed for providing care and then sort of all of the costs related to that care is bundled into that payment. One thing I would say about that is I think increasingly metrics are going to be looking at whether a patient received an HIV test or not. So if the payment is bundled, the HIV test, the organization that's kind of negotiating for the bundled payment needs to negotiate for performing the HIV test, because that increasingly is going to be how individual providers, individual health systems are evaluated, because it's a relatively easy metric to follow. But yeah, I think the funding is always a challenge. Traditionally, a lot of HIV testing has been funded through the federal government, through grants that go to states, and then grants that go to community organizations. And increasingly, we are trying to shift the funding for HIV testing to being able to bill for the test, and so that those HIV prevention dollars that were being spent on HIV testing could be used for other HIV prevention interventions. And part of the money there hasn't been a change in the total amount of money that's being spent from a federal standpoint on HIV testing, but part of that money is now going to help systems work on being able to bill for and be reimbursed for their HIV testing. So I don't know exactly what state that question came from, but I would encourage you could follow up with us, obviously, but also follow up with the state health department, because that is a key activity that we're trying to work on really in every state to help organizations, particularly ones that are providing testing among people who really need HIV testing, to be able to get reimbursed for that service.
Great, thank you so much. And with that, I will go ahead and conclude the Q&A session. I would like to thank again our presenters, Dr. Jenkins, Dr. Peters, and Mr. Amos, for participating and giving such valuable information. Thank you again, participants, for joining the Integrating Routine HIV Testing into Primary Care Strategies for Improvement in Partnership webinar produced by the National Healthcare for the Homeless Council. This webinar will be archived on our website at www.nhchc.org within 3 business days. A link to the archived webinar will be emailed once it is posted to our website. At the close of this webinar, you will receive a survey link to evaluate the presentation. Please complete the survey so that we are able to improve your webinar experience. We invite you to visit the National Healthcare for the Homeless Council's website for a full listing of upcoming and archived council webinars as well as other educational products. This meeting will now be closed.